Good morning, everyone. No, sorry, good afternoon. It's 1 o'clock. We will give everyone just another minute or so to join, and then we will get started. All right, well, why don't we hop in? So thank you so much, everyone, for your interest in today's webinar. We're really glad you all are joining us. I'm Adara Citrin. I'm CHBRP's Associate Director, and I'm joined by my colleagues Anshit So and Anna Pickrell. For logistics, please enter any questions you have during the presentation into the Q&A function on the webinar. We have quite a bit of time at the end to go through all of the questions. We'll also post a recording of this presentation and the slides to our website after this. So I'm going to kick off the webinar with a quick overview of CHBRP, and then we'll get into discussions about what health insurance is, how it's regulated in California, and some helpful publications CHBRP has available for stakeholders. So for those of you who are newer to us or would like a refresher, CHBRP was established in 2002 through California legislation and conducted its first analysis in 2003. We receive requests directly from the legislature to analyze health insurance benefits and other health insurance related legislation. These requests typically come from the Assembly or Senate Health Committees, but may also come from the Appropriations Committees or others in leadership. CHBRP's primary charge is to provide neutral, evidence-based analysis of legislation, but we also provide other resources on health insurance policy for the public. We are always available to help folks understand our work or answer questions about health insurance and benefit mandates. To give you an idea of what our analyses look like, every analysis will provide some context to give an overview of what is happening at the state, federal, and sometimes local levels related to the policies in question. We also provide some background information on the subject of the bill. So just so everyone knows, we are not lawyers. We are tasked with making reasonable interpretations of each bill that is referred to us. We do reach out to the Department of Managed Healthcare, the California Department of Insurance, and the Department of Healthcare Services to ask questions about bill interpretations. Next, we examine the medical effectiveness of the tests, treatments, and services included in the bill by looking at the existing evidence and providing a grade for it. Is this treatment effective? Is there really strong evidence, some evidence, or is there not enough evidence available to make a conclusion, and so on? Finally, we estimate the cost impacts in the form of premium and cost-sharing changes, as well as the public health impacts on a population health level. We have videos available on our website that provide more information on how to read a CHBRP report and other good CHBRP tips. So next I'll dive into a little bit of what is health insurance. Health insurance covers medically necessary tests, treatments, and services and protects against some or all financial risk due to health-related expenses by spreading risk among groups of enrollees. Health plans pay for some costs, while enrollees pay for other costs. Specifically, health plans are responsible for covering benefits and reimbursing providers who deliver those services to enrollees. So as I mentioned, health plans cover medically necessary tests, treatments, and services. Typically, these services are divided between the medical benefit and the pharmacy benefit. The medical benefit covers hospital care, outpatient care, including primary care, specialty care, and outpatient procedures, laboratory tests and diagnostic services, and emergency and urgent care services. The pharmacy benefit covers prescription medications obtained through a retail pharmacy, a mail order pharmacy, or a specialty pharmacy. There are some services which may be covered under both or either benefit. For example, physician-administered medications are typically covered under the medical benefit, but may also be covered under the pharmacy benefit in some instances. Now I want to talk about the different types of plans and policies offered by insurance companies. Enrollees frequently have a choice regarding which type of plan or policy they enroll in. Health maintenance organizations, or HMOs, involve a specific set of providers, require a referral to see specialists, and typically have lower premiums as well as more predictable out-of-pocket costs. Preferred provider organizations, or PPOs, typically have a broader provider network and do not require a referral to see a specialist. Premiums for these plans tend to be higher than those for HMOs. Two other types of plan and policy offerings include exclusive provider organization and point of service plans, which combine aspects of both HMOs and PPOs in different ways. And lastly, high deductible health plans are plans with lower premiums and higher out-of-pocket costs. Provider networks vary and may be narrow or broad. Healthcare costs are shared between health plans and enrollees to help incentivize keeping costs low. Enrollees are responsible for three healthcare expenditure types: premiums, cost sharing, and non-covered expenses. There is some variation in which expenditures enrollees pay and how much, depending on their plan type. Premiums are a monthly payment made by enrollees, or a combination of enrollees and their employers, to health insurance companies in exchange for health insurance coverage. Cost sharing refers to the amount that enrollees must pay directly to the provider for a covered healthcare service or treatment. Cost sharing encourages enrollees to use healthcare services judiciously, which helps in maintaining lower premiums for all enrollees. Looking into enrollee cost sharing a little bit more, the mechanisms include deductibles, the amount an enrollee pays out of pocket before their health insurance pays for covered benefits, coinsurance, a percent of the cost of a test, treatment, or service that an enrollee is responsible for paying after they meet their deductible, and copayment, a flat dollar amount an enrollee pays when receiving a test, treatment, or service. Enrollees typically pay for cost sharing up until they reach their out-of-pocket maximum, which is the most a person will pay for covered healthcare services in a plan year. Out-of-pocket maximums include deductibles, copays, and coinsurance, but it does not include premiums or out-of-network care. Some services are not covered by health insurance. For enrollees that use these services without insurance coverage, they are responsible for the full cost and pay the provider directly. Common examples of non-covered benefits and services include cosmetic procedures, experimental or investigational treatments, and then also and alternative medicine. And dental and vision services are usually require a separate insurance plan or policy. So when we look into cost sharing a little bit more, there can definitely be variation in how cost sharing is structured. And this really varies between insurers and even within plan options from the same insurer. Deductibles may be specific to the medical benefit, the pharmacy benefit, or could apply to both. There are a lot of differences between not only the types of deductibles, but also the amount of the deductibles. Some plans are called high deductible health plans and have a higher deductible in exchange for lower monthly premiums. Enrollees may also have higher copayments or coinsurance responsibility when enrolled in these plans. Whether a plan has cost sharing also varies. Some plans, including all state-regulated CalPERS plans, do not have deductibles. Medi-Cal also does not have any cost sharing at this time, including deductibles, coinsurance, and copayments, although this will change in the near future. And lastly, sometimes cost sharing just doesn't apply. For example, many preventive services are covered without any cost sharing. Some plans are eligible to be used with an HSA or an FSA, and these are health savings accounts or flexible spending accounts. These are accounts that an enrollee can contribute pre-tax dollars to and can use the funds to pay for cost sharing for covered services or other qualifying costs as specified. These two types of accounts are similar, but not identical. Some notable differences are that HSAs and FSAs are available through different plan types. HSAs can be used with a high deductible health plan or a marketplace, bronze, or catastrophic plan. And FSAs are typically associated with an employer-sponsored group health plan. HSAs belong to the individual for life, whereas FSAs are owned by the employer. This means that when someone leaves a job or drops coverage with their employer that has an FSA, they typically lose access to that FSA. HSAs and FSAs also have different contribution limits, and when you can contribute differs. An enrollee can contribute to an HSA up until the tax filing deadline for the year. Enrollees can contribute to an FSA at the start of the year or when they enroll in their coverage through a special enrollment period, but cannot be changed during the year. Employers can contribute to an employee's FSA. And also, rollover terms are different between the two. Unused funds roll over in an HSA, and FSAs allow some amount of rollover, but it does vary. So in California, there is a core set of benefits that plans and policies are required to cover. There's also some overlap between the requirements, although there is variation as to which plans and policies are required to cover these services. The first set of benefits I'll talk about is the essential health benefits, which is a broad set of 10 categories that the Affordable Care Act requires. And this applies to most small group health plans and policies, and also individual plans and policies. These categories include maternity and newborn care, preventive services, emergency services, prescription drugs, and behavioral health treatment, among others. Another set of services specific to California is the requirement for health plans to cover basic healthcare services when medically necessary, including hospice care, preventive health care, inpatient and outpatient hospital services, home health services, and emergency care. There is quite a bit of overlap between the essential health benefits and basic healthcare services, but there are also some differences. For example, the essential health benefits requires plans and policies to cover prescription drugs, which the basic healthcare services does not. However, both sets of laws require coverage of emergency services. There are also multiple laws at the federal and state level that require coverage of preventive services. California and federal law requires coverage of a defined list of preventive services without cost sharing. Preventive services such as immunizations, wellness visits, and cancer screenings are covered without cost sharing. California has numerous other benefit mandates in state law, applying to all or a subset of state-regulated health insurance. Examples of California-specific mandates include fertility preservation services, prohibition of cost sharing for abortion services, and telehealth coverage and reimbursement. And with that, I will pass this over to Anchi.
Thanks, Adara. Hi, I'm Anchi. So I'm also a principal analyst with CHBRP, and I'm going to be talking about different types of health insurance. To start off, I want to talk specifically about the state-regulated health insurance. And to be clear, the next handful of slides that I'll be walking you through are all specific to the medical benefit. So the majority of Californians are subject to state-regulated health insurance. And I want to make sure it is very clear, if there's one thing that you take away from this, is that CHBRP deals primarily with state-regulated health insurance. And most of the bills that will come through the legislature will not impact every single Californian. They will impact a smaller subset of them. So you won't necessarily actually be impacting all 40-ish million Californians with legislation, at least with health insurance. Out of the buckets of state-regulated health insurance, this includes Medicaid, which is called Medi-Cal in California. It's a public program that's primarily for low-income individuals. It's the one exception to this rule, actually one of two exceptions to this rule, because Medi-Cal is also federally regulated. There's also CalPERS, which is the California Public Employees Retirement System program. This insurance is primarily for public employees and their dependents. The majority of CalPERS programs are regulated by the state, but again, one of the exceptions. Some of it is also federally regulated. And then going into the private insurance markets, we've got small group plans and policies, and this is for employees or 1 to 100 employees per business. At the federal level, it's a little bit of a different definition. But in California, a small group is defined as 1 to 100. And then we've got the large group employer-sponsored plans and policies, which have 101 or more employees. And finally, there are individually purchased plans and policies that can be acquired through Covered California, which is California's marketplace for the Affordable Care Act. They can also be purchased directly through the insurers. For those who do purchase insurance through Covered California, there is financial assistance available to those who are income qualifying. So moving on to federally regulated health insurance, these typically do not fall under CHBRP's purview, although every so often we might see a Medicare bill. There are three major programs or plan types that we generally think about. One of them is Medicare. This is for populations who are over the age of 65 years, but it also includes people with certain disabilities and those with end-stage renal disease. There's also insurance for military veterans and active duty military. So this includes TRICARE, which is for active military and their families. But it also has some veterans, and then Veterans Affairs insurance, which is for veterans and their dependents. Finally, there are self-insured plans. So this is a health insurance for businesses that make the decision to take on the risk of providing healthcare for their employees. And they are subject to only federal laws. Now, I want to talk a little bit more about Medi-Cal and the differences between them, because it's a very large part of our system. There are two major ways that the state pays for health insurance for Medi-Cal beneficiaries. One system is through fee-for-service, and one is through managed care. So under the fee-for-service system, the Department of Healthcare Services, which is the administrator for Medi-Cal, they pay providers directly for every service that's rendered by a physician. What this does is it creates an incentive to maximize the volume of services provided to patients. And in this model, the financial risk is held by the state. Under the managed care model, DHCS, or the Department of Healthcare Services, pays health plans a fixed monthly fee. This is also known as a capitated rate for each member within the plan. And then the plan then contracts with healthcare providers through different networks of organized systems of care. Under this model, the incentives are to create efficiency, prevent diseases and conditions, and increase value-based care. So the risk in the managed care model is held by the plan. So if costs exceed the capitation rate that is agreed to between the plan and DHCS and the state, the plan will lose money. Some other differences just to note between the two systems is that provider choice is generally broader under the fee-for-service model. You as a patient can visit anyone who takes Medi-Cal. However, the reimbursement rates for Medi-Cal tend to be a little bit lower, so not all providers accept Medi-Cal. Fee-for-service also under that model, there isn't a health plan that's actually coordinating care on your behalf, whereas the managed care model, that's part of the health plan's job. So for the purposes of CHBRP analyses, there are a small number of Californians who do have coverage still under the fee-for-service model. However, the state has, in general, transitioned most people over to the managed care system. So in CHBRP analyses, we make the assumption that all Medi-Cal beneficiaries are in the managed care system. And now I will pass it over to Anna.
Thanks, Anchi. Okay, I'm going to finish up with a little bit about health insurance in California, specifically looking at enrollment in these various markets we've been talking about, and a little bit more information about some other regulators in the state. So as part of our bill analysis process, CHBRP develops annual projections of health insurance enrollment in California by market segment. And what we have found for 2026 is about 33% of Californians are enrolled in federally regulated health plans. So, again, the types that we don't tend to look at, but still helpful to know how many Californians are in there. So, about 14% are on self-insured plans. About 14% are on Medicare, and then about 1% are enrolled in other kinds of public plans. So that's things like TRICARE and Veterans Affairs that Anshi mentioned earlier. Most Californians are enrolled in state regulated health plans. So for 2026, we estimated that's about 60% of Californians in state regulated insurance. The majority are either in Medi-Cal or large group plans. So about 24% are enrolled in Medi-Cal in 2026, 22% in large group plans, and then about 6% in small group plans, 6% in individual plans, and 2% in those state regulated CalPERS plans. Having a state regulated medical benefit doesn't necessarily mean that an enrollee has a state regulated pharmacy benefit, which I know is a little confusing. So in 2026, about 95% of commercial and CalPERS enrollees who are enrolled in state regulated plans have a state regulated pharmacy benefit. So it's not everyone, but it is many. And that is for brand name and generic drugs. A small portion of them, of those commercial and CalPERS enrollees, so about 4%, have a pharmacy benefit from some other source. And an even smaller portion, about 1%, have no pharmacy benefit. Medi-Cal beneficiaries receive their pharmacy benefit through what is called the Medi-Cal RX program, which is a carve out, and it is managed by the Department of Healthcare Services. So I know we've talked a lot about the Department of Healthcare Services, just to give you all a sense of who the regulators and administrators are in the state. The Department of Managed Healthcare, or DMHC, regulates most commercial state regulated plans, most CalPERS plans, and Medi-Cal managed care plans. Plans regulated by DMHC are subject to the Health and Safety Code, or the Knox-Keene Act, which is the set of laws that were passed by the state legislature in 1975 that authorizes DMHC to regulate healthcare service plans. The California Department of Insurance regulates a portion of commercial health policies and plans, and those policies and plans regulated by CDI are subject to the insurance code. And then finally, as we've mentioned, the Department of Healthcare Services, or DHCS, administers Medi-Cal, which differs from regulating the program in that DHCS oversees Medi-Cal program management and financing. And again, they manage the Medi-Cal RX program. So that is the extent of our fundamentals of health insurance content for our presentation today. But I want to walk through a little bit of an overview for you all on the kinds of publications that we provide on our website that can serve as support and reminders for anyone working in health policy in the state. So our website houses all of our past bill analyses. There are many. You can spend as much time as you want going through them. And they also include corresponding key findings documents, so kind of a shortened summary for every bill. And then in more recent years, we've also started producing 1 to 2 page infographics for our bill analyses. So for the bills we have completed those are also on the website. In addition to our bill analyses, our website houses multiple types of publications that are not bill specific. They come in 3 different levels of kind of depth or complexity. First, we have a glossary on our website with key health insurance terms that we keep up to date. And then we also have what we call our nuts and bolts, which are high-level snapshots of key health insurance topics. They tend to be short, 1 to 2 pages, and provide visual aids to understand various topics, including things like California's proposed 2027 EHB plan, There is a new one on AB 144, which was passed in September. The one explaining these kind of new regional state health alliances, a timeline of the HR1 Medicaid provisions, one nuts and bolts on the sources of health insurance in California. There's one on enrollee healthcare expenditures and a handful of others. These are just the newest additions. Leveling up a little bit, our next sort of level of complexity and depth are our explainers. They are slightly longer, more of a deep dive into broader topics. We develop explainers based on topics we hear being frequently discussed in the legislature or in the healthcare field more broadly. Some recent examples of new explainers include overviews of health insurance in California, kind of a 101 there, one explaining what is cost sharing, another on utilization management, one about the Office of Healthcare Affordability, another one on Medi-Cal RX, which we mentioned earlier, and one on the drug supply chain. Again, among others, these are some of our newer topics. And then finally, we have some materials we call resources, as well as some issue briefs and policy snapshots. These publications help build a deeper understanding of some of the hot topics in healthcare. They tend to be a little bit longer than some of our other publications, and again, cover a wide range of topics. Our resources are updated annually with publicly available data and data collected from the health plans and regulators. So some examples of those resources that we update every year include sources of health insurance in California, federal and state preventative services benefit mandates, pharmacy benefit coverage, and deductibles in state regulated health insurance. Our issue briefs and policy snapshots are similar to resources in their level of depth, but they are snapshots of topics in time and are not updated over time. So some examples there include AI and healthcare in California, outpatient prescription drug cost sharing, telehealth, and the medical necessity determination process, again, among some others. And then finally, if you can't find a publication on our website at any of those levels on a topic that you want to know more about, we are open to suggestions for new publications. So please reach out via email or on social media if you have suggestions for us or questions about anything you find on our website that isn't clear. We are available on all of these social media outlets that you see here, and this QR code goes to our CHBRP listserv if you would like to sign up for that. We do not send a ridiculous volume of emails, we promise. And that is about it. So I think we can go ahead and take questions now.
Thank you, Anna. We have one question in the Q&A. How do HRAs differ from HSA and FSA accounts? Adara, you want to take that one?
Sure, happy to. So HRAs or health reimbursement arrangements are not actually health insurance. It's a way that employers can reimburse their employees directly for the healthcare services they obtain, also not through insurance. So if an employee goes directly to a physician, pays cash price for that office visit, they can then submit the claim or the receipt to their employer, and their employer will provide that reimbursement through the HRA.
Thanks, Adara.
Yeah.
Any other burning questions?
I also want to flag, I think we didn't mention this, but some of our slides, which as Anshi mentioned in the chat, we will send around, some of them have links in the top right corner to the resources and publications on our website that house the information on those slides. Maybe we did mention this at the beginning, but if you flip through these slides, there are links to kind of more detail on some of those topics if they are of interest.
Also, we've started receiving requests for bill analyses. And if you are interested in knowing what we are up to, you can follow us on any sorts of social media. We also have a listserv. I know everyone says this, but we don't really spam anybody. We basically notify folks when we get an analysis, when we've published an analysis, and quarterly updates are typically how much mail you get from us. So I will put a link in the chat for our listserv. It's a really ugly link, sorry. But we would love you to join the CHBRP fam.
Well, I'm not seeing any other questions come up in the Q&A. So why don't we conclude our webinar? Thank you very much, everyone, for joining us today. Please feel free and reach out to any of us. Our emails are on the website. We're always happy to have a conversation, answer questions, provide more information. So don't hesitate to reach out. And yeah, we will get to work analyzing all of these bills that we've been requested to analyze. So happy Thursday. Take care, everyone.